what happens in the skin with lupus? You're going to get rashes, right? So what is the rashes we have? Huh?
The butterfly or the malar rash?
The malar rash, okay. What is that? So what if they don't tell you malar rash? Instead, they call it acute cutaneous lupus erythematosus, okay. Cutaneous lupus erythematosus is implying the patient's got a malar rash. What else, rash-wise? Huh? You can get a discoid rash, and now that discoid rash is actually a chronic rash. They call it chronic discoid lupus, okay. Whereas the third one is going to be photosensitivity. The photosensitivity rash, that is actually subacute cutaneous lupus erythematosus. So now that everyone's gotten comfortable with malar rash, photosensitive discoid, they're going to take that terms off and call it acute cutaneous lupus erythematosus for malar rash. The next one is subacute cutaneous lupus erythematosus is photosensitivity. And lastly, which is chronic lupus erythematosus, is going to be your discoid rash. Now, out of your malar rash and your discoid rash, which one is scarring? Okay. Now, let's start with the brain and work our way down. What can happen to somebody with lupus to their brain? They can actually have psychosis, okay? They can have encephalitis, they can present with delusions, they can have seizures. Why does it happen? Can you get a vasculitis that actually affects your CNS? Yes, it's called primary angiitis of the CNS, which is associated with lupus.
Lupus pneumonitis.
Yes, you can get lupus pneumonitis directly affecting your lung. What else?
Alveolar hemorrhage.
Alveolar hemorrhage, yes. Pneumonitis and alveolar hemorrhage, yes. But apart from that, what happens to your pleura? Pleuritis. Now, important thing about lupus, it can cause inflammation of all your pleural surfaces. So your lungs, your pleura, right? So you would end up something called pleuritis. And pleuritis pain, when people come to you, they're always going to say, I got chest pain when I take an inspiration. Deep breath in and out, you're going to have a lot of pain. So pleuritis can happen. Okay. Anything else in the lungs apart from pneumonitis and alveolar hemorrhage? Not really. You can get pleuritis. Okay. What about the heart with lupus? You can get pericarditis. Now, when somebody comes with pericarditis, chest pain, how are they going to present?
Sensitive.
It is sensitive, but what is more specific for pericarditis? From an EKG standpoint, it is PR depression. It's not ST segment elevation, but PR depression is going to be your most specific test when it comes for pericarditis. Now, when you have pericarditis, remember, you can always develop a pericardial effusion. The pericardial effusion can get bigger, which is going to lead to pericardial tamponade. So when you start developing pericardial effusion, the pericardial effusion is really large. What would you see on an EKG at that point? Low voltage QRS is going to be first, but the moment when you develop pericardial tamponade, you would see electrical alternance is what you're going to see. Okay, so a lot of time when somebody's got pericarditis or pericardial effusion, you must also get an X-ray. An X-ray will tell you the heart looks quite big. Okay, but the moment you start suspecting pericardial effusion, your worry should always be to if the patient's going to develop pericardial tamponade, right? So always going to get an echocardiogram to see if there's increased amount of volumes that's causing collapse of the ventricle, right? Okay, so pericarditis can happen. What else can happen in the heart? What else can happen with lupus? What happens in the blood? Huh? Okay, so you can actually have a hypercoagulable state due to what condition? Anti-phospholipid syndrome, right? So if you think of anti-phospholipid syndrome, what's happening there? You have antibodies against your coagulation cascade. But these antibodies against your coagulation cascade, are they destroying the factors, or are they making them, because they're attacking them, they're making them form clots everywhere and using it up? So typically, if somebody's got an anti-phospholipid syndrome and you did a PTT or an INR, what would happen to that? Would it be prolonged? Because as a lab test, when you get a lab test, if there's any antibody against your coagulation factors, it's destroying it or making a clot with it, its functionality is gone down. So your PTT will be prolonged, right? So what's your next step if you have a prolonged PTT in a patient with lupus? When it comes to your hypercoagulable workup made for real life or actual exams, right, we love to speak about different conditions that can make you hypercoagulable, right? What is the most common reason for being hypercoagulable? Acquired or genetic, actually?
Latent.
Inherited is factor V laden first, followed by
Protein.
prothrombin gene mutation. Okay. Factor V first, prothrombin gene mutation. Nobody cares about third place and below, right? You only care about first or second in life. After that, nobody cares. Okay. So, who comes at third place? Does not. Absolutely not. So that's this board question they love to ask. They tell you somebody's got a first time unprovoked DVT. How long do you anticoagulate for?
Unprovoked.
First time unprovoked, 3 to 6 months. First time provoked, 3 to 6 months. What if they're factor V latent positive? Doesn't change anything. What if any of the other 4? Doesn't change anything. Second time provoked clot. How long do you treat for? 3 to 6 months. Does it change your management if you're any of these positive? Provoked. It does not. Second time unprovoked. Second time unprovoked clot. Lifelong. Whether you are factor V or any of this positive doesn't matter. Second time unprovoked is lifelong anticoagulation. So that's important to know. Now when it comes to antiphospholipid syndrome, that actually increases the risk of first time clots, second time clots, third time clots, just goes on.
Yeah.
Venous clots, arterial clots, all sorts of clots. This is a bad thing. Okay. So if somebody's got antiphospholipid syndrome, what is your anticoagulation of choice? If you're in a hyperinflammatory cell, right? If you have lupus and there's a lot of damage to lots of tissues, same analogy as what we used yesterday for rheumatoid arthritis. When you have any rheumatologic condition that's destroying a lot of tissues, do you have increased cell turnover? You do. If you have increased cell turnover, you need to make a lot of DNA? Yes. To make DNA, to make purines, you need folic acid, right? So if you don't have enough folic acid, you're going to run off folic acid, and then you're going to develop folic acid deficiency, which is going to lead to megaloblastic anemia. So you can actually have pancytopenia. Again, the reason pancytopenia, you need DNA to form WBCs, hemoglobin and platelets, everything. So everything's going to go down, right? So you can actually have pancytopenia there. Okay. What else can happen hematologically speaking?
Is there increased risk for like osteonecrosis?
Not so much. Unless you're using a lot of steroids, then sure. But if not, no. Could you develop a hemolytic anemia with lupus? Answer is yes, because you will produce IgG antibodies, okay? IgG antibodies, and IgG is actually known as a warm agglutinin, right? Remember, it's an opsonin. The macrophage in the spleen loves anything that's attached to IgG. So lupus can actually cause warm agglutinin disease. So you'll end up with a hemolytic anemia in this patient. So remember, from a hematologic standpoint, you can actually have anemia of inflammation, you can have pancytopenia, you can have megaloblastic anemia, you can also have a normocytic anemia, which is hemolytic. So it could be multiple different things. No, you can have ANA positive with a lot of different conditions, right? So what is going to be your diagnostic test with lupus? Disease activity. Okay, if somebody is having an acute flare-up of lupus, and if you wanted to check certain things to see if they're active disease, what are you going to check for? How do you treat lupus? Like your mother drug for rheumatoid arthritis was methotrexate. Your mother drug for, now this is normal lupus, but you can also develop drug-induced lupus, right? What are the drugs that causes drug-induced lupus? Hip drugs? Are you guys hip or not hip? You guys are hip? You all are all hip people?
Sure, yes.
Sure, okay. What does H stand for? Thank you for watching. If you like our content, please like this video, subscribe to our channel, and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.